السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبد الله ورسوله. It's a really hot topic, and it's a rather an philosophical, ethical, more than a scientific question. And I will not promise with a lot of science and fancy molecules, but maybe we have to think out together and to revise our conscience and revise our ego in making decision for what we ought or ought not to take a decision about. First of all, we have to set a rule down that one size does not fit all, and we have many discrepancy along the way of dialyzing a patient with metastatic cancer. And let's revise some case scenarios which might look obvious, but you have to look deeper inside. Potentially reversible AKI is a 54 years old father of 2 teenagers currently undergoing treatment for cancer, and he develops AKI secondary to ATN, and he may imminently require dialysis. Would you dialyze him or not? Performance score and patient goals. This is a 67 years old female with CKD stage 4 with a newly diagnosed monoclonal gammopathies and Karnofsky performance score more than 50, and she develops a superimposed AKI secondary to myeloma kidney. And the patient's previously stated preferences to continue to work and remain independent. So this is her value. Would you dialyze her or not, and for how long? A potentially poor outcome. This is an 86 years old nursing home patient, started on dialysis 6 months ago. He is already on dialysis. And he is wheelchair dependent for 2 months. And he's admitted with pneumonia, and accidentally he was found to have a new hematologic malignancy. Would you withdraw dialysis or would you keep him on dialysis? Another patient with poor outcome, 80 years old female with CKD stage 3 and metastatic breast cancer with no further treatment option regarding her oncology plan, and she develops AKI that might be potentially reversible. Would you dialyze her or not? And she had some uremic symptoms. And maybe last case, 70 years old male dialysis patient with cancer undergoing chemotherapy treatment, and he develops septic shock and multi-organ failure and is transferred to the ICU, 2 weeks aggressive therapy. He is ventilatory dependent and unable to be weaned. His living will states that he would not want to live on life support if there is no realistic chances of returning home. The family insists on continuing aggressive medical care, support till the end. Would you dialyze him or not? So these cases gives a real conflict in the decision. It might seem easy from the medical point of view to take a decision by dialyzing a potentially reversible acute kidney injury and withdrawing or withholding or foregoing dialysis for a patient who is very late and terminal on dialysis. But things are not going along all the time. So let's revise the scenario. Are you dying? ما تنساش تلقن البيشنت الشهادة. This is the most important thing that you can do when he is dying person. The outcome is not simple survival. It's not simply how much he would live. It's the cost of treatment, the quality of life, the symptoms and its severity, and the society, including the caregiver and the social burden, and the chance of recurrence, and even the location of metastasis. For example, some patient might have, with metastatic cancer, a 1-year survival of high percentage. So you should not deny, for example. Others could have less than 6 weeks survival expectancy. So you would change your mind in this situation. And beyond simple survival, the metastasis, for example, to bone or pleura, is not imminently life-threatening. Whereas liver, lung, and brain, they have very much reduced life expectancy. Patients with liver and lung metastasis usually would expect to have less than 6 months of survival, whereas patients with widespread or lymph node metastasis might have less than 6 weeks of survival. A patient with brain metastasis is a dilemma because it will be according to the size, the number, and the location of the metastasis, and survival can range from days to a year or so. Some cancers have their own complication, which might be more aggressive than the metastasis itself. For example, recurrent hypercalcemia, sepsemia, malignant recurrent pericardial and pleural effusion, abdominal carcinomatosis with ascites, and bowel obstruction from a malignancy inside the abdomen have a very, very less favorable prognosis. Other important prognostic consideration consider the Charlson comorbidity index. How much is the patient comorbid? Is it the renal failure and the cancer alone, or is he a geriatric patient with multiple comorbid conditions and high frailty index? Again, whether the primary is a known or unknown is a very important factor in the survival of the patient. A metastasis from a cup, or what's known as cancer of unknown primary, usually have much less survival than a metastasis from a known primary. So what's your role? Would you only say معلش to the kidney and we're going to lose that kidney and nothing to do? Or would you interfere? And where is the wisdom in this area? Where is the place that you would give the decision of dialysis in a wise manner, and where is the place where you withdraw dialysis or withhold dialysis in the same wise manner? First, you have to understand that they are not all alike. Causes of renal failure differs when it comes to a patient with a cancer. It could be just pre-renal fluid depletion, hepatorenal syndrome, or drug toxicity. It could be glomerular secondary to direct glomerular injury and immunoglobulin deposition. It could be tubulointerstitial from an ATN or acute interstitial nephritis, or again immunoglobulin deposition and drug toxicity. Vascular, like in TMA and others. Or it could be obstructive, like with many drugs that can cause crystalluria and obstruction of the tubules, methotrexate and others. And these are pretty much of examples of causing these different types of pre-renal, glomerular, tubulointerstitial, vascular, or post-renal. And it's not always tumor lysis syndrome that we, of course, all knew about. And just revisiting the pathophysiology of tumor lysis syndrome, disruption of the tumor cell because of outgrowth or chemo or radiotherapy concomitantly, mainly in hematologic patients, would cause release of the intracellular components with the potassium, phosphorus, and the nucleic acid, with the accumulation of uric acid, the hyperphosphatemia, and the hyperkalemia, causing the arrhythmias and the muscle weakness and the paralysis, maybe the heart block, along with the acute tubular obstruction and the renal failure. And as you all know, essential treatment is hydration and alkalinization of urine, and you might need dialysis. So knowing this background about the causes of renal failure in those patients, what is your decision? On what basis are you going to decide? Of course, you should have the balance of the benefits and the harms. And you should integrate your own medical view, which is only one aspect of the scenario, along with the patient preference, which is a very important point, with the expected quality of life to the patient and the contextual features. What is the social, economic, and legal aspects of treating this patient, both for his cancer and his renal failure? And of course, you should review the 6 ethical principles which is the autonomy, which is the patient's own right to take his decision, and the beneficence that you are doing no harm. It is, as we all know, premium non cure. And the non-malfeasance, yani you are not doing harm to the patient, justice, you are allocating equal values or equal chances to similar patient, and respect for the person, and the truthfulness and honesty. And of course, having the private sector in our practice does have a heavy shade on this practice. So truthfulness and honesty is a very important aspect of managing those patients along this criteria. So you would have these different scenarios. Patients with end-stage renal disease who develop terminal metastatic malignancy, or patient with terminal malignancy who develop end-stage renal disease, and patients with terminal malignancy who develop AKI. So would you do withdrawal for the first patient, or would you do in the second patient withholding the dialysis, or foregoing dialysis in the third patient? And usually the nephrologist will be stuck. As we all know, when it comes to nephrology, everyone raise his hand and بلغوا الكلى. Everyone, even the oncology, for an oncologist, for a patient with terminal metastasis, would tell him, only if your creatinine comes down from 2 to 1.3, I will give you the magic treatment and your cure will be at your fingertips. Of course, this is not the case, and we all know. But they always incriminate the kidney. And this puts the nephrologist under pressure, that I have to do something, because he is saying that the kidney is the barrier between the cure and the patient, and you have to evaluate. And as we know, nephrology is not a branch of medicine. Medicine is a branch of nephrology, and we should all be aware of all other potentials in all other branches of medicine to take a prompt decision. So you would be asked to provide dialysis by the patient, by the caregiver, by the next of kin for the patient, or even by your fellow colleague. And the clinician should not fear their medical or legal concerns. There is no obligation if you see that this is not in the best value for the patient. And it should be, after all, a shared decision making. Do not be stubborn. It's not you alone. You are part of the view or the scenario. And you should resolve the conflict. And resolving the conflict involves many, many ways to go through, starting from talking to the patient family in a good way, or the patient himself in a proper, honest, and wise, truthful way. And you might convince him with your point of view. If you fail to do so, you can just bring someone else to talk to him. A consultant, a medical consultant, an ethical or a religious consultant, just to persuade him with your point of view. If you fail to do so, just transfer the patient to another colleague. He might have some other approach to convince the patient. If you all fail to do so, transfer him to other institution or other hospital. Then if you failed, go to the ethical committee. Go to the logistics and logistics committee, even to the court. And if you failed, you have to go along with the patient's own will, because you cannot deny him his own will, whether it's with or withholding. He is, after all, unless you have a court verdict in the view of the general society benefit. But for the patient benefit, you cannot deprive him from his own will. So dialysis therapy versus non-dialytic medical therapy. And this is an important issue. Denying dialysis to a patient does not mean that you're leaving him to die. You're still going along with the maximum medical support, but without going to the dialysis. Sometimes dialysis might be associated with more burdens, like in a frail patient or a significant number of comorbid conditions, and when the prognosis is bad. So let's take our decision. First, ask your patient, what's your concern? And what you most need right now. Realistic and empathic discussion about potential quality of life changes, symptoms, burden, and complication associated with dialysis allows a patient to make decision with his preference. Start with cancer. If the patient is candidate for treatment or cytotoxic cancer, this will differ accordingly. You would have the Karnofsky Performance Status Scale and the Eastern Cooperative Oncology Group Performance Scale. Generally speaking, if your Karnofsky Performance Scale is greater than 50, you might offer dialysis to the patient. If it's lower than this, probably this patient wouldn't get benefit or survival benefit from dialysis. And it's all based on the daily activity. It's easy to understand this performance scale. Is the patient frail or not? What his functional age is, not only the biological age or chronological age. And with the kidneys, do you expect dialysis will solve the problem, or do you expect the patient to survive on dialysis? I mean, is it just a hyperkalemia that is transient and the patient might pass through and continue his journey fighting the cancer? بعون الله, ولا he is not going to survive and he will need dialysis regularly for a couple of weeks and then he will die or succumb on any account. So you have to know what the kidney. If you have two of these four comorbid, two conditions, maybe the patient has a poor outcome on dialysis if he is 75 years or older, if his Charlson comorbidity index is more than 8, and just to know that a cancer patient with metastasis have a CCI of 6 alone. If he has a renal failure, so this is 7. If he had diabetes, so this is 8. So you have to fix out what is the Charlson comorbidity score. Marked functional impairment if the performance score less than 40, and severe malnutrition with a patient of albumin less than 2.5. And this is the Charlson comorbidity index. So would you try a limited time of dialysis? He might get away with it. Or would you continue dialysis on? Again, would you do a palliative dialysis like we're doing incremental or infrequent hemodialysis, just symptomatic treatment, not on a regular schedule? All these are questions to be answered and to be tailored and individualized per patient. Let's go back to our patients. So the first patient, when the cancer prognosis is uncertain, the patient is young and the AKI is potentially reversible, you should try a limited trial of dialysis and looks what's going on. Don't deny dialysis to those patients. With a patient like this, he had a functional decline and awareness of the dialysis trajectory and the risk of functional decline on dialysis should be emphasized to that patient. Although she looks a little bit young, she's 67 and just recently diagnosed with the monoclonal gammopathy, but you have to discuss the functional ability and the burden of dialysis. This 86 years old patient, he would be in a palliative care and you would consult a hospice care evaluation. ده هينزل في نزل أو في دار مسنين فيها تمريض. And you can give him the non-dialytic medical treatment. Maybe doing dialysis is an overdoing in this patient. And this other patient, you should forego dialysis.
Dear doctor, your time is up.
No value. There is no value of going back with dialysis in this patient. You should withhold or forego dialysis for this patient. And for the last patient, dialysis withdrawal would be the wise decision. Although he is on dialysis, but he is on the ICU, there is no way to just take him off the ventilator, and he now had malignancy on top of his pneumonia. So what's the value of doing dialysis on the regular schedule because he is already on a dialysis schedule? there is no value, definitely. And again, it's philosophical and ethical issue, and we have to discuss with ourselves first, then go to our patient, then go to our colleagues and discuss the scenario all together, and I thank you here.